research in the history of medicine. It's libraries, archives, museums, digitized collections, digital exhibits, huge series of objects and documents that have been digitized. So for example, all of Darwin's works have been digitized and are together on a website. So also all the grants that are available at McMaster for undergraduate research are also here. And it took me and a PhD student 2 months to get this. So if it takes 2 people with PhDs 2 months to find this information, I say, what are the undergraduates going to be doing to try to get that information? So I strongly recommend that you look at the grants section. It's really important, and there are a lot of things that don't go applied for that have 1 or 2 applicants because they're not really advertised. So whatever your interest and whatever your research background, I strongly recommend that you take a look at the grants section. And there should be copies of the cards right over there by the cookies conveniently located. So take one on your way out. It's a great pleasure to introduce our speaker today. Dr. Pierre Minn is assistant professor in the Department of Anthropology at the Université de Montréal. He completed his BA in anthropology at Yale University and his MA and PhD in anthropology from McGill, finishing in 2011. He's conducted ethnographic fieldwork in Haiti since the late 1990s, focusing on health systems, humanitarianism, international aid, and global health. His work has been published as articles in American Anthropologist, Medical Anthropology, and Duke University Press. He is now the principal investigator for the Appui au Continuum du Soin Mère-Enfant project, which we can translate roughly into English as the support for continued care for mothers and children, a 5-year Global Affairs Canada-funded Canadian initiative that aims to reduce maternal and infant mortality in northern Haiti. His research is part of this $11 million project that includes building infrastructure, quality of care improvement, training for local staff, He has just returned, just now, from 2 weeks teaching research methods in Rwanda at the Centre Hospitalier Université de Kigali, in Kigali, Rwanda. He has a monograph in preparation entitled Where They Need Me, Local Clinicians and the Workings of Global Health in Haiti. Today he's going to talk to us about his ethnographic fieldwork in global health programs entitled Aspirations of Leadership in Contemporary Global Health Education. Please join me in welcoming Dr. Pierre Minn.
So thank you very much. A huge thank you to Ellen Amster and to everyone working with her. Thank you so much, Neha, for arranging for this visit, for coordinating the room, for getting the word out about the talk. It's a real pleasure to be here. And this talk is for me, it's been a long work in progress that actually began here in Hamilton as part of a workshop organized by Andrew Gilbert from the Department of Anthropology on international intervention. And it's been one of these research projects that I've been doing parallel to my work in Haiti. And there's been some uncertainty about what was going to happen to this study and this project because it wasn't clear what was happening with global health education, which is an emerging phenomenon. And I think there still is a lot of uncertainty as this curriculum gets established, these programs get formed. We know that something new is happening, but what global health education will look like in 10, 15, 20 years is still very uncertain. So I look forward to hearing your comments and questions. And just out of curiosity, how many people here are based at a global health program and affiliated with it? So, okay. And how many are from social sciences, maybe from anthropology? Or, okay. So it's a mix, and it's an interesting mix to have anthropologists, historians, and folks working in global health, either as clinicians or as researchers. So I'm going to start by using just a couple of internet websites. I don't have a formal PowerPoint, but the sites illustrate some of the phenomena I'm going to be talking about. So the rapid growth of global health training programs in North American universities is really nothing short of extraordinary. And this is the website for CUGH, the Consortium of Universities for Global Health, which the last time I checked it had 109 universities offering global health degrees or tracks. And this can be for undergraduates, graduates, or professional students. And nearly all of these programs were established or renamed in the last 20 years. So in a relatively short period of time, you either had schools of public health or of international health that became global health through a sort of rebaptism, or programs that were created where there hadn't been an equivalent before. If we look just briefly at this website, we look at some of the member institutions. This is for the maps. And then later down, McMaster is of course here, and you have major medical schools who were either involved in the founding or who are present now, and ranging, again, mostly concentrated in North America, but also a small number in the global south. And this is one of the challenges for CUGH, is that many of the universities, if you just look at the graphic where they are concentrated, indeed many of them are in North America. So there was a report in 2009 that tried to identify why are there so many new programs in global health. And these were the directors of Duke University's Global Health Institute, who identified 3 factors. So the first one being significant changes in American higher education that places greater emphasis on and resources for internationalization in response to students' greater awareness of the world starting at an early age and facilitated by the global media. And this is one of the very interesting things about the emergence of global health education. The first global health course that I taught at McGill when such a course did not exist was in 2005, and it was because undergraduate students wanted the course. And so they lobbied social studies of medicine, where history of medicine, medical sociology was already being taught, to teach a global health course. And it really came from the students who guaranteed that they could get sufficient enrollment that the university would benefit from having such a course available. The second, heightened public visibility of the global health agenda as a matter of U.S. foreign policy and as part of a larger movement for greater global equity. And much of the story that I'm going to be telling here is a very U.S.-American story, and I think that's important to emphasize. And then finally, expansion of resource flows. So the U.S. government, foundations, corporate and private philanthropy have generated new opportunities for universities and potential career paths for students. So looking at the emergence of what's called global health, anthropologists have been looking at many facets of global health, including biosecurity, the expansion of pharmaceutical markets, infectious disease control, and humanitarianism. So you have some explicit work on the relationship between anthropology and global health, not very much yet on global health education. And then you have work in sociology where people have been studying medical education for a long time, back classic studies to the 1950s and 60s, and it continues to be an ongoing source of interest for sociologists, is to understand how are clinicians being trained. But in terms of global health training, we don't have very much understanding of what's going on in these programs. 2 of my colleagues, Betsy Breda, who's at Reed College in Oregon, and Noelle Sullivan at Northwestern, have been looking at encounters between global health students from American medical schools and clinicians in Botswana and Tanzania, respectively. So they've done some nice ethnographic fieldwork looking at what happens when medical students or residents from the United States are in African hospitals. But looking at what happens in the North American classroom, from what I've seen, there's very little that has been examined from the perspective of social sciences. And this is interesting because medical anthropologists have been involved in designing a lot of these global health programs. So they help set up the curriculum, they help contribute to what the pedagogy will be. But they are just one of many disciplines that are represented. And one of the things that we see across the board in global health training programs is that you have the kind of interdisciplinary dynamic we were talking about earlier that sometimes can be collaborative and sometimes can be a series of struggles for power and trying to get access to student time or classroom time. So many of the disciplines that we see in global health include epidemiology, clinical medicine, biostatistics, and then you also have other fields which will be represented in a smaller number. So medical history, sociology, sometimes medical informatics, and fields such as engineering and pedagogy, which depending on the program can have more or less of a place. So my interest in this subject of trying to understand how and why people are being trained in global health stems from encounters with younger aid workers that I met during my research on international aid in Haiti. And the predecessors, the older people who had been doing international aid in Haiti, many times came to the country with no formal training in international or global health. And they usually were being trained in clinical medicine, developed a relationship oftentimes with missionary doctors, and formed sort of an apprenticeship. So how do we practice medicine in Haiti? A lot of times it would be based on the people who had been there before, other Americans or Canadians, especially in the Haitian context. Whereas the younger folks that I saw who were coming to Haiti to do aid in their 20s and 30s often would say, oh no, I'm doing a global health degree, or this is part of my global health track, or I'm here as part of a global health internship. So it was much more formalized in terms of before they were arriving in Haiti, the classroom experiences that they had, and also their own intentions in terms of training, careers, and degrees. So the study that I've done is an attempt to describe and analyze these trainings, how they're shaping contemporary global health interventions. And these interventions, as we know, shape the lives of millions of people around the world, particularly in impoverished settings. So to carry out this study, I conducted ethnographic research primarily at the Masters in Global Health Sciences program at the University of California in San Francisco. And this, I chose this program because it was the first in North America to offer a global health sciences master's starting in 2007. There had been a program already created in the UK, but in terms of the US or Canada, they're very proud to identify themselves as the first. And UCSF is an interesting place for global health because they do not have deep roots in international work, such as when compared to places like Johns Hopkins or Tulane. But what UCSF had was an enormous expertise around HIV/AIDS because of the number of HIV patients they saw in San Francisco starting in the early 1980s. And then this translated when they became interested in global health. So the UCSF Masters in Global Health Sciences program is 8 months of coursework, including epidemiology, biostatistics, communicable diseases, qualitative and quantitative methods, economics, policy, and then an overview course, which you find in a lot of these programs called Foundations of Global Health. And these courses oftentimes end up being sort of a who's who institutionally. You're smiling because you have a similar course possibly. Who are the institutions? Where is the money coming from? How are things organized? Who's responsible for doing what? Students also enroll in elective courses that can cover more specific topics. So at UCSF there were courses in women's health and courses in cost effectiveness analysis. And many of the faculty members, when they're teaching these courses, stress that because of the brevity of the program, they would only be able to offer an introduction to and overview of the subject that they were teaching. And so there was often this feeling during the course that everything was compressed, or if you want to learn more, you need to go elsewhere, or we're just skimming this, or this is just the basics that you need to know. That kind of language came up a lot, so the program had a very hurried feel. So after their 8 months of coursework, the UCSF students would go do what was called a capstone project, and that was 8 to 10 weeks. Towards the end of the academic year, they would conduct a research project on a topic that they developed with their respective faculty members. And so this could be independent or semi-independent studies on original or existing projects, analyses of data from ongoing studies, and then more exceptionally, literature reviews. There was really the idea that the best projects would be collecting original data or a field research project. Even if it was part of somebody else's ongoing research, the literature reviews were sort of seen as like, you know, you couldn't get your project really off the ground, so you'll do a lit review. Approximately half of the students in the recent cohorts are going to travel to what is known as resource poor settings, including sub-Saharan Africa, Latin America, and Southeast Asia, while the other half remained in the Bay Area, either because their work focused on marginalized and impoverished communities in or near San Francisco, or because their research didn't entail fieldwork. And after they completed their research, they would return to San Francisco for a final period of coursework, and they would write up their capstone projects. So during my study of this program, I attended courses at the program's headquarters, which were situated in a high-rise building in downtown San Francisco, where many of UCSF's global health research and training programs were based. And they were paying a huge amount of tuition from the students, was actually going to rent for that building. And they have since moved to a new campus at an area of San Francisco, a very formerly impoverished area called Mission Bay, and Global Health has now moved there. So the courses in the main conference room were very crowded. There was about 40 students during the cohorts that I were there, a faculty lecturer, teaching assistants, and then the program's directors would come and sit in regularly. So sometimes if they had guests, there were people standing in the back. You can imagine this kind of cramped room in an office space in San Francisco. So during my fieldwork, I would sit in on the lectures, and then I would observe and participate in the small group discussions that followed the lectures. These would be discussions about articles that had been assigned, and then I spoke informally with students between their courses. The courses are about 30 hours a week, so it's course intensive. And in addition to that, I also attended other university-based global health events in the Bay Area, mostly out of UCSF, but also out of Stanford and at UC Berkeley. So these were lecture series, 2 conferences of CUGH. The consortium holds an annual conference. The next one's going to be in Chicago, if any of you are interested. It's their 10th anniversary conference. And since many of these institutions maintain active and richly documented websites, I was also able to make use of extensive online resources to try to understand the content, form, and nature of emerging global health pedagogy. So this helped me situate what UCSF was doing in the field as compared to other programs. And then finally, I conducted in-depth, semi-structured interviews with a total of 31 students in the master's program in the 2013 cohorts. And these were conducted at the end of the students' academic years when they could reflect on their experiences in the program on the whole. So I talked to these students about their reasons for undertaking graduate studies in global health. Why would you do a master's in global health sciences? To reflect on the program and its content, and to contrast what they were learning in the classroom versus what they had seen during their capstone projects, or if they had done other types of global health work in the field. I also asked them to discuss their own impressions on the rising popularity of global health among students, and to describe their aspirations for future involvement in the field. And the themes of leadership and partnership specifically began to emerge as central topics early on in the interviews. I asked students to talk explicitly about how they conceive of these terms, leadership and partnership, and to describe how they had been addressed in the curriculum. The program's directors had given me permission to introduce myself and present my study to the students by emails, and by the time I had contacted the students at the end of the course, they had seen me sitting in their classroom for the year, so they knew who I was. Interviews lasted between 40 and 90 minutes, and it took place at a location that the informants chose. Usually it was at the UCSF Global Health Sciences building. So today I'm going to be talking about several dimensions, all related to leadership in global health. And I should be upfront and say that I have never liked the concept of leadership. I remember hearing it when I was in high school, and it was something that people were training us to be leaders, and we were going to be leaders in the leadership training programs. There was so much emphasis on this term, and I've really had to do my own soul searching. Why am I suspicious of this word and kind of skeptical of this word? Is it because it's too general? Is it because it was very clear that it was about adults trying to tell young people what kind of people they should be when they grow up? But this leadership language and vocabulary, it gets traction in certain spaces, and it's extremely present in global health. It is totally absent in anthropology. We never tell or talk to our students about becoming leaders in anthropology. The professional associations might do that, but it's absent from seminars, from the pedagogy, from the classroom. So it's interesting to see when and where leadership language emerges, and who talks about it, why and when. And then actually, one of the big reasons I had to give up my resistance to the term and think about it differently is that my colleagues in Haiti are so interested in leadership, and they're so interested in a style of governance that would be an alternative to what they have seen in the Haitian context, where they define their national situation as a lack of leadership. And I've heard the same thing in Rwanda, I've heard the same thing around the world. So I try to set my own prejudice against the term aside, listen to how people are talking it, and why people what the stakes are for people investing in the idea of leadership, and then in these cases, training leaders. So before I talk explicitly about leadership, I'm going to discuss the place of cases in global health training, both in the coursework and in new forms of case competitions that are growing alongside these university training programs. And in looking at both the issues of cases and leadership, I'm looking at how global health has been influenced by the language, concepts, and logics of managerial and business education. So management sciences and business administration are here, not necessarily explicitly, although sometimes you will see courses in global health management, but the logics of leadership and of these cases, I'm arguing, are as really coming from this source. So to talk a little bit about cases, the term case in global health, as in clinical medicine and in law and in other fields, is used to describe both an empirical problem or a situation, as well as an example that involves specific parameters and distilled conditions that facilitate its use as a teaching tool. So you can have the case of a patient, or you can have a legal case, but in all of these fields you also have cases where you're going to be teaching something and extraneous information has been filtered out, and you're directing students towards some kind of specific problem that they have to solve. So cases in global health education can be real or fictional, and they're used for all sorts of reasons, variety of ends. They often appear in didactic lectures and presentations. So for example, students at the UCSF program, they may be presented the case of water contaminated by arsenic in Chile in order to illustrate the long-lasting effects of pollutants on cancer rates in a population. Another professor used the case of HIV treatment strategies in Botswana to highlight the effectiveness of employing community health workers in controlling the rate of communicable diseases. Cases appear frequently in the texts that accompany lectures. These articles and chapters generally present an overview of a health topic in a global scope before using one or more cases or specific examples or illustrations of the issue in question. So as mentioned earlier, the use of cases is not restricted or unique to global health. Rather, it illustrates how global health is drawing on pedagogical strategies from other established disciplines. In many of the courses I attended, the hour-long lectures were followed by exercises in which students were asked to divide themselves into groups of 3 to 5 students and to discuss cases from their readings for that day. Or they would also sometimes be attributed cases on the spot. And so they would have printouts with a paragraph or two of a specific global health case. They were given this text, and then they were asked to talk about it and sometimes develop strategies. So for example, after being presented a brief text that describes high rates of malaria among infants and children in Tanzania, the students would be asked to design or react to a health strategy or policy that would remedy the problem. So these cases usually came with instructions that had character directives with them. You are the members of a WHO working group. You are members of the Tanzanian Ministry of Health. Students would then be given a period of 30 to 60 minutes to discuss issues relevant to the case and prepare a plan of action, and then that would be presented to the larger group of 40 students. In many situations, almost all situations, students would rapidly create a PowerPoint presentation to project what they had found and what their strategies would be. So in nearly every one of the case study exercises I observed, students were asked to assume the theatrical role of decision makers, interveners, and allocators. And these are the roles, of course, for which they're being groomed in their training. This is what they are aspiring to become. There was only one case where I saw students being attributed the role of a beneficiary group. So when they were handing out who was going to be who in the case, one group of students were told that they would be a group of mothers of sick children in a rural village. And the gap from global health students at UCSF to impoverished village mothers in Africa proved to be quite a stretch. So when the students were impersonating aid workers, policymakers, or government officials, they assumed these roles very seamlessly. They spoke in their own voices, they spoke in the first person, but when the students were asked to embody the village mothers, they chose to recite their positions and their perspectives all together, and it was kind of the effect of a Greek chorus, kind of theatrical, and it incited some laughter among themselves and the audience who was there. So it was very clear to me that the students were not making light of or making fun of the predicaments faced by impoverished mothers in villages, but that this position in the global socioeconomic order was very difficult, if not impossible, for students at an elite American university to embody convincingly, whereas projecting themselves into someone working at the WHO or someone responsible for a university partnership, that everybody did without batting an eyelash. So for the most part, in these cases, students are being asked to assume the roles that they hope and aspire to attain in the future: director, decision maker, other intervener. This is not remarkable, given the objectives and nature of the program. However, this approach designs the global health sphere as one in which students, as global health workers, have autonomy, control, and leadership over resources and decisions. Since the exercises are intended to develop their sense of agency and action, the scenarios present situations in need of interventions, scenarios with missing actors that they can fill in short, a world of problems that can be repaired by North American students' reflections and actions. I rarely or never saw instances of students being asked to create scenarios to correct or modify or abolish existing interventions, despite the fact that virtually all contemporary global health projects today are directed towards populations who have been the target of national, transnational, or non-governmental health efforts of one form or another. So the model is you're creating something from scratch. You're not improving, you're not modifying, you're not transforming something that already exists. Students were uniformly presented with a blank canvas in need of something new. So the use of global health cases, which implicitly requires students to constantly prove their ability to design interventions for a wide array of setting, also orients students towards specific kinds of mobility and interchangeability in their future work. Researchers and clinicians working in university-based global health programs are remarkable for their mobility. The biographies of the researchers and clinicians, including my own right before this talk, often contain statements listing the numerous countries in which they have worked. And there was one case of a UCSF researcher, the number of miles he had traveled in the previous year on his webpage, which was 150,000. While many global health researchers maintain long-standing relationships with individuals and institutions in specific project sites, students were often presented with the promises of extreme mobility. And this reflects what Peter Redfield, an anthropologist working with Doctors Without Borders, has called the unbearable lightness of expats. So in being asked to prepare policies and project for Tanzania on Monday and Guatemala on Wednesday, students are given the message not only that their measures and tools are universal in their potential and transferability, but that they themselves are or will be able to move in and intervene across radically different sites. And this is really enabled through the use of the case as a pedagogical tool. A final example of the uses of cases in global health training that illustrates their pervasiveness on a wider scale is the emergence of global health case competitions. The largest of these is Emory Global Health Case Competition, which has been hosted by the Global Health Institute at Emory University. And I was delighted to learn that McMaster won 3rd place in 2018. Was anybody here involved in this competition? I would love to talk with you about this. This is my kind of wrap-up project for this, is to actually follow a team and follow them to Emory as they prepare this. So, and you can tell me if this has changed, but the format is that the teams, oftentimes there will be a competition within a university, and then the university will send teams to Emory. I believe there was 24 teams in 2018, something in the 20s. And the students will receive a case on Monday evening and then prepare a presentation that they present to a panel of judges the following Saturday, followed by a rapid period of questions. And so just for example, the case in 2013 required teams to recommend for China specific sanitation programs and for countries for Beijing to invest in. So teams have to consider the feasibility and likelihood of the success of the sanitation programs they propose, as well as the economic benefits that China would receive for investing in the proposed country. So the teams have to develop programs that they anticipate Beijing will be able to invest in. And then some of the other cases required students to justify a fictional Canadian agency's presence in Sri Lanka, develop programming for the UNHCR's regional office in East Africa, and make recommendations to the Gujarati government on how to reduce health and economic burdens relating from tobacco use. And the case this year, we can take a quick look. The 2018 case involved the World Cup in Qatar in 2022, and developing a strategy to address an infectious disease outbreak prior to the World Cup. And this year, maybe we can talk about conspiracies, but the team from Emory actually did win the competition, and they stress this. It's the first time since 2012 we're not winning every year, and then University of Minnesota and McMaster, and then there's some honorable mentions. So the case competition has become quite well known, and like I said, you have smaller versions around the United States and Canada. While the explicit goals of case competitions are to teach teamwork, innovation, problem solving, and presentation skills, they can also be used by recruiters and agencies to identify talented students or solutions to problems. So one of the Emory competition coordinators remarked in 2012, they will attract people who work at the Centers for Disease Control in Atlanta and for different consulting firms. And one of the organizers commented that people will come to them after and say, these competitions are amazing, can we have them, can we integrate the suggestions into our own work? And sometimes internships are included as part of the prize packages for winning teams in the case competitions. So I found this idea of a case competition for global health very striking. And one of the goals of anthropology is to make the familiar strange. And so looking at this saying, oh, okay, well, you know, it's a university competition for students. Well, why did it take the form of a case competition? And why does it last a week? And what are they being asked to do and prepared? And the fact that this has been such a success attests to the synergies between contemporary global health education and the logic and language of training in business and management. And case competitions began in the United States in the 1980s in business schools to solve financial and marketing problems. And one of the first business case competitions was at the University of Virginia, the McIntyre case competition, and it started in 1982. And this was the goals that they set out. The competition has 3 objectives. This is for a business case competition in Virginia. To demonstrate the abilities of our undergraduate students, to provide an opportunity for participants and their schools to gain international exposure, and to offer a forum for faculty from among the world's finest business schools to discuss issues in international business. And I think that these objectives still hold today in terms of global health. And in the years that followed, the number of competitions has increased rapidly. Now they're sponsored by universities, by private companies, organizations, and foundations. And the specific characteristics of each case competition can vary. The underlying concept involves a team receiving the same case, preparing solutions or recommendations during a limited period of time, and presenting their results to a panel of expert judges. So what the Emory competition will say about themselves, they describe themselves as a unique opportunity for students to come together to promote awareness of and develop solutions for 21st century global health issues. Okay. The influence of business and managerial education is visible not only in specific events such as this case competition, but also in the form and the content of the sustained training programs. The directors of the Masters in Global Health Sciences clearly stress that their degree is an academic rather than a professional degree. And this question also, in terms of are people being trained for research, for academia, or as professionals, as would be the case for a master's in public health or a master's in social work, the folks at UCSF say explicitly, this is not a degree primarily to be undertaken in search of a career direction or to look for a job in global health. They say that they're looking for students who have a clear idea of what they want to do with this degree and why it fits into their anticipated career trajectory at this time. And what's fascinating about UCSF, I'll just come back to their program for a moment, is that their original audience was students who were already enrolled in medical school. So UCSF is only a health sciences campus. They don't have a law school, they don't have social sciences other than pertain to medicine. They have a medical school, a nursing school, and a school of pharmacy. And the directors told me that when they set up this program, they were really aiming to recruit medical students, nursing students, people in fellowships and residencies, people who were already on their way to becoming clinicians. And it ended up being a big surprise for them that this is not who ended up taking the course. They have some, and they will regularly have some people who are either practicing clinicians or clinicians in training, but they have a much larger than expected proportion of students who have just completed their undergraduate degrees. And that was a surprise for them, but it also is now becoming more than half of the students who are enrolling. And that is raising a series of questions for them in terms of what are these students now being trained for? Are they future clinicians? Are they going to be doing epidemiology? Are they going to be doing public health? And one of the fascinating conferences at CUGH was listening to the deans and directors of these programs saying, is it ethical what we are doing? Is anybody going to hire someone with a master's in global health degree? And I think now, for most of the programs, the track record is clear that people with global health degrees either do go on to other studies or get employed. But at the beginning, it was very interesting to see people debating this because they knew that they would be able to find students because of the popularity of the subject. What they didn't know is what the outcomes would be for these students, especially if they hadn't received clinical training. So I'm going to move now to talk explicitly about leadership. And again, leadership language is going to be present in the case competitions, so it's related. But leadership is a particularly prominent theme in many of these programs' self-representation. So how they attract students and how they describe what they are doing. The first paragraph on the program's introductory website for UCSF says, The Global Health Sciences Master's degree is a one-year, four-quarter program designed for students or practitioners in a health science profession or related field who wish to achieve mastery and leadership skills in the emerging field of global health. Graduates are prepared for leadership careers in international policy, healthcare, research, and development. So UCSF does not have a specific course called Global Health Leadership, although there are such courses that exist. For example, University of Washington, that is the name of the entire course. At UCSF, rather, leadership language is pervasive in all of the courses, in all of the disciplines, in all the subject area. It will be talked about in terms of particular skills to acquire, particular practices that should be encouraged, or a leadership style approach. And one of the most significant sources of leadership training, according to the UCSF program, is that the students come into contact with global health leaders. And this is something that they promote throughout the year, is that their professors, their faculty members, the people that they're going to hear talk are leaders in their field. So for example, several global health sciences faculty are featured on the website in capsules called Everyday Leadership, Tools for Teaching Leadership and Management in Global Health. And there you have clinicians, epidemiologists, people who are running programs who give their vision of leadership and talk to students. The idea is that it's targeted for UCSF students, but could be available to anyone, about their vision of what leadership is for global health. Students who are enrolled in the master's program were very aware of this aspect of their education. And when I asked them why they chose this program in particular, one of the things that kept coming back in the students' answers was the reputation of their faculty. And the students would use the term leaders, but they would also use other terms signifying prominence, including global health heroes, and my personal favorite, global health rock stars. So contact with these prominent individuals is presented as one of the key strengths, and this contact will occur through small faculty to student ratios, individualized mentorship for the capstone programs. And after hearing this term over and over and over, it occurred to me that the students are never asked to become global health followers, right? They're in contact with global health leaders so that they themselves can become leaders. And I one time Googled global health followers to see if anything came up. And nothing does. The only thing that did come up was a poorly worded paragraph about people who are following a listserv, but there's no such thing as a global health follower. So the program is not training followers, they are training leaders through contact with other leaders, and training the next generation of global health leaders is used by Duke, Emory, Harvard, Northwestern, Columbia, and so many of the other universities that are training people in global health. So in their position as future leaders, students can offer the other members of their cohort their promise of their own future influence and connectedness. So in addition to talking about the benefits of being in contact with people who already had prominent careers in global health, the message was constantly being given that the people sitting around you are going to be global health leaders in the coming decades. So the term networking was also used frequently in the program to describe interactions that would eventually lead to global health opportunities. That was another word that came up a lot. And these are namely possibilities for future educational or professional development. While leaders such as faculty and mentors represented particularly desirable targets for networking, students also spoke about the wealth of experience, talent, and potential they found within the cohort, so among the other students. So during the interviews, they would often comment on the diversity of their fellow students in terms of disciplinary background, occupational background, ethnocultural origin, social background. Students spoke of each other both as valuable resources within the context of the program, but also in terms of future exchanges and relationships. And this is going to be a facet, obviously, of any form of graduate training. So it's not surprising that it would be visible in global health as well. People are selecting their programs based on who they think other graduates are going to be in 10, 15, 20 years, and who they can connect with, particularly in a short period of time. So this master's program is over the course of a single year. Others might be over 2 years or over a similar period, but the idea was that you had to move quickly to network with people that would eventually be either inspirational figures or people who would help you professionally. So then I asked the students to speak specifically about leadership as it was presented to them. And all of the students stated that it had been a recurring theme and a key term over the course of their training. So here are some quotes on the official discourse. The students say, they're always telling us that they're training us to be the next generation of global health leaders. So they recognize that that's an explicit goal. Others noted that specific faculty used the term leader more than others, but that it's commonly mentioned throughout the year. In response to my questions about the kinds and forms of leadership that were presented to them during their time in the program, nearly all of the participants mentioned public speaking. And this was something that really, for me, surprised me. But this was the theme that came up the most often, was the ability to present one's idea clearly and convincingly before an audience was a skill that students are continually being asked to develop and refine, particularly through brief oral presentations accompanied by PowerPoint slides. Students also mentioned being asked to lead or facilitate small group discussions or debates, which also will have a very kind of verbal or rhetorical component. So these forms of leadership these were the first things that the students mentioned when I asked them, well, you know, what are they actually training you in as leaders? What are you doing to become future leaders? These forms are intimately tied to language, communication, and verbal practices, using spoken word to impress and convince others to accept information, concur with an argument, agree with a strategy, or approve of a course of action. So in response to my questions about their own conceptions and visions of leadership, in the global health sphere, some of the students I interviewed expressed their agreement with those that they attributed to the program's staff. And so for them, there wasn't a big difference in terms of what they were being taught and told, and kind of their own idea about what it meant to be a leader, that this idea of being convincing and doing charismatic public speaking was something that was really important and that would be important in their careers to further one's priorities and project in global health. A few of them, not many out of the 30, described leadership in terms that directly reference or overlapped with your standard dictionary definitions, which usually focus on the capacity to influence the actions of other individuals or direct a group. So that's oftentimes what we'll find when we look up standard definitions of leadership, is are you able to influence the actions of others? But there were also a small number of students who gave definitions that contrasted explicitly with those that they attributed to the program's directors and faculty. So one student told me that she believed in what she called leading from behind, arguing that the strongest and most effective leaders were not particularly visible to those that they were leading, but rather had the capacity to influence others and promote agendas without drawing attention to themselves or without maintaining a highly visible public profile. And the leading from behind expression was particularly interesting because it was used by President Obama to describe US military actions in Libya, and that's when it circulated not long before I interviewed these students. So the links between military and leadership will show up in surprising ways. One student in particular, who happened to be very introverted but recognized by her peers and program faculty as a particularly promising researcher, told me that she disliked public speaking and she planned to pursue a career in global health that allowed her to follow her interests without having to maintain a prominent and visible public persona. But she was quite the exception, actually, in the group. When I talked with people about their career goals, whether they were in research or in administration or in policy and programs, many of them talked about the fact that they would be in careers that would require them to use these public speaking skills. So in attempting to understand the contours and stakes of contemporary global health training, I think it's always important to keep in mind the relative novelty of these programs, that they really have emerged very recently, that many of the faculty, or nearly all of the faculty who are teaching in them, were not themselves trained in global health. They were trained in other disciplines, and they are being asked, or they have chosen to develop global health curriculum. And many of the faculty that I spoke with talked about their uncertainty in terms of what did this mean to put this program together. There's a lot of consideration of what the other programs are doing. They may be exchanging explicitly at conferences. They are looking at each other's websites. They're using the information that circulates in putting these new forms of training together. So because UCSF in particular was the first master's in global health sciences in the United States, it's already being used as a model. And so I'll meet people from other universities who say, oh yeah, we looked at UCSF's program, we tweaked a couple things, but we're essentially going with the framework that they used. Or Duke is also often mentioned as one that was there early on, and other programs are saying, so we're going to do it the way that they've done it with the coursework, the capstone, we're drawing from their curriculum. Part of the controversies around these new programs, however, is that some of the universities have public health programs that have been established for a century or more. And I mentioned at the beginning of the talk, Tulane, Johns Hopkins, and others, many of them who had been doing international work and who see global health pedagogy and curriculum being done by people who are relatively new in the field, or who had not been involved in public health before, who are coming at it from more clinical approaches, and that has created some friction, including an article a couple of years ago by deans of public health schools. The article was entitled, "Global Health is Public Health," and they were affirming that they were not changing the name of their school or their program, and arguing essentially that the goals of global health and the global health competencies that are being developed essentially are repeating tenets of public health. And that's kind of an ongoing debate in terms of, is this old wine in new bottles? And I think that there's arguments both for and against looking at continuities, but there is something new that's emerging. So we end up looking a lot at public health and at clinical medicine for where global health pedagogy is coming from, because that's the official affiliation of many of the faculty and the program directors, right? They are doctors of public health, they're clinicians. But what I'm hoping is that in this talk, we can see how fields that may not be explicitly represented, business, administration, and management sciences, are having a presence, obviously not just in global health, but in other disciplines throughout universities. And there is an internal self-critique from these fields. So in one of the videos that I talked about, the founder of UCSF's Global Health Program, who's a physician named Haile Debas, who is originally from Ethiopia but trained in medicine in Canada, he describes how individuals with MBA degrees have been hired to lead global health programs, but then that they end up getting dismissed for what he calls a lack of vision. So on one level, business administration, managerial sciences offer tools that can be useful in global health, but there may be dissent growing from within the field that it's not 100% compatible, and this lack of vision that he describes for people with MBAs may have to be remedied with people with other forms of training or career trajectories. So I think I will end there. Thank you very much for your attention, and I look forward to hearing any questions or comments that you might have. Thank you.
So I'd just like to bring the lights up so we can think about the shadows there. Oh, that's the wrong window. There we go. So Dr. Minn, thank you so much for your talk. I think I have some questions, but I want to open the floor for anybody who's got some questions right away.
Thanks very much. That's very interesting. For these programs, a lot of master's PhD programs, we struggle with the outcomes because we don't really follow students. Has anybody followed up on masters of global health students to see what they actually do 2 years or 5 years down the road? Is that being looked at?
UCSF has actually done a pretty good job of that, and they were able to do it because they started with such a small cohort. When they started in 2007, they had 6 students, all of whom were from within the university, and all of whom were given free tuition for the program. They were a pilot cohort, and the tuition for this program is $40,000. Not to mention living in one of the most expensive cities in the world. When I was in San Francisco, single, like just a one room was on average $2,500 a month. So the investment was serious. People who were paying for this, and they weren't offering financial aid until 2014. But because they had a small cohort that started with 6 and then went to 12 and went to 18, they've actually been able to do, up until now, a pretty good job of keeping track. And what they found is that a significant percentage of the students are still in school. So this master is leading to other degrees, and so a high percentage of them are still in training. Some of them may be working in a related field. They don't give very much details, and obviously because they're publishing these numbers, they can't talk about students who don't pursue fields in global health or reorient. And it's a project that I would actually be very interested in looking at eventually, is what I've affectionately called global health dropouts. Because global health, what I've seen in terms of intervention in Haiti, tends to attract 2 large categories of North Americans: people in their 20s and people who are on the verge of retirement, whose children are grown and which allows them to travel internationally, or who have had successful clinical careers. This was the case for a lot of UCSF faculty. They said, you know what, I've earned a good living as a doctor, I've had really interesting work, now it's time for me to do something for someone else, and so I'm going to start doing HIV work in Uganda. That was very typical, but you didn't have a lot of people between 30 and 50 doing the international field work just because of the mobility that it requires. So what you have is a lot of people in their 20s who they or their families are investing enormous amounts in these programs, but who knows what is going to happen to them, even just professionally, with time in terms of global health engagement or involvement. But I think that at this point, if the programs are keeping track, and that's where we have to look, is official, kind of what the programs are saying, they may be cautious about sharing that information if it's not what they think future students want to hear. Like, what, they're still in school 8 years after they graduated from your department? That might not be very appealing. Or maybe it is.
Do you think the pervasiveness you said of leadership that was throughout this program and other programs that you surveyed, like other global health programs, do you think that that's just because, do you think that that might be an extension of how we teach health to healthcare professionals and business right now? Like, if you take a business course, or if you do your MBA or anything like that, it's the same thing. You're going to be the leader in the business.
Yeah.
If you do your MD, you're being taught you're going to be the leader in health. Or if you're doing nursing, you're going to be the leader in nursing. If you're doing a master's in nursing, it's always about being a leader anyways. So
yes.
It just feels like it's just because of an extension of the health and what we teach in those fields.
Absolutely. I think it gains traction, and I think that but what I find complicated in terms of global health is so much. You also have, while you have all of this focus on leadership, there's also this discourse about community participation, about grassroots involvement, and so many of the lessons and models around health for impoverished populations do not involve charismatic leadership. They involve broad-scale economic change and governance that are not based on single individuals. And a lot of times that sort of gets pushed out. It's a sort of easy coexistence that, yes, like community participation, community buy-in is so important, or partnership, like an equitable partnership. But it always kind of comes back to charismatic leadership. And that's why I think that the idea about aspirations is so important, because, in a sense, it's sort of selling a dream of saying, like, we are trying to attract people who will enroll in our program to become something. And there's the idea of, like, someone who's already a born leader, or someone who just needs a little help with some leadership skills, but then they will become the person that they want to be. And that, personally, as a vision of global health for me, is quite troubling. Again, because it is so focused on the charismatic individual, and then we see in the history of public health, like, how, certain individuals get held up as heroic figures, but what does this do? I look at this a lot from the perspective of Haitian clinicians, who are not being told that they're going to become the leaders of anything unless they leave their country, right? And so these programs are not doing very much to support, let's say, nursing education in Haiti. For a nurse who's not going to be a leader, she's going to be, one of 4 nurses in a small clinic where she doesn't have a lot of resources, and There it's about her managing her social relations and being able to respond to patients and trying to get some resources together. And of course, there's going to be forms of leadership in that, but that's not where the emphasis is. The emphasis is really on strengthening a very, very weak health system. And I think leadership plays a part in that, but the fact that it gets so much attention, I think, is also indicative of our idea of medical heroics, of the legacy of missionary medicine, of what we've done to Paul Farmer, as a charismatic figure. Why does he occupy this role? Why did he become this visible figure? That's also what he's being asked to do, and that's to represent a white savior doctrine.
This is fascinating. I really enjoyed your talk. As someone who's technically in the global health specialization here at MAC, I think we don't often get like that meta lens back to us, and this is almost like, I love anthropology for making the familiar strange and things like that. And I'm actually, what do you see as anthropology as I think of global health as much broader than just one master's. I think me doing a medical anthropology degree is still relevant to me wanting to do some form of global health work, and I've been looking into medical anthropology, how that might fit into what we consider global health. And also, I have so many questions, but I'll start with that.
Yeah. So I think there's a couple different things that I think about. When you look at what anthropologists do in these programs, a lot of times they're invited to come in and give a talk about culture.
Yeah.
And that's very frustrating because we're trying to leave culture behind, right? Like we don't use culture as a concept very much anymore because it's trying to open a small nut with a sledgehammer. And so, I think historians also, come give us the historical perspective, right? Like you have, like where did we come from? And there's just this expectation that it'll, be in this kind of development. And we've learned all the past lessons, and now global health is at the pinnacle, fixing what international health did wrong. And that's kind of what we're being asked to do. I'll be asked to say, well, how come patients don't want to boil their water or vaccinate their kids, or like why do they, believe that they get possessed by spirits or whatever. Okay, like that, that's not what I do, but at the same time, I will sometimes use that to get my foot in the door.
Yeah.
And to make contact. So I'm speaking as an anthropologist who will, if I get an invitation to talk in a global health program, I'm there, and I will try to see who, is going to be open, because especially people who have done more extended field work, they know that it's not just about like the other's culture and the exotic other. There's an awareness of complexity, and my work with biomedical professionals from a poor country is already very, very destabilizing, right? The Haitians are not just HIV positive patients waiting, for ARVs, but that they are doctors, that they're nurses, that they're dentists, that, there's med schools in Haiti. Yes, there's med schools in Haiti. It changes, the dynamic, and they're like, well, what do they teach them? What do they learn? What do they think when we come down with our programs? And so the fact that I'm, an anthropologist of professionals from a resource-poor country lets the conversation go elsewhere. But it is tricky also because a lot of anthropologists are being funded through global health programs. So a couple of my colleagues, including Noelle Sullivan, and she talks very openly about this, she is at Northwestern because students want to do global health. So she comes with very critical perspectives about what it means when medical students go to Tanzania and will gossip among themselves about where you can actually participate in a C-section, right? Without the qualifications for doing so. They talk about this in internet cafes, and like that hospital, you can go do that work. And so, she talks about this explicitly. At the same time, she knows that her position is tied to a global health budget. So it's, it's walking a fine line sometimes. I will say though that, for people at UCSF and other people that I've met, and I think this is part of, a critical anthropology of biomedicine. When people have been doing this for a while, they're already critical. And they are open. Now, to what extent they can make structural changes. But usually if I present this to a very global health audience, what I get is recognition. They're like, oh, you're putting words on something that we see but we hadn't articulated, right? And my methods allow me to do that as an anthropologist. But I also, I don't feel like I'm sneaking around looking at how bad the global health people are. Like that's not, that's not what I'm interested in doing, and that's not the dynamic that's set up, because these folks are very smart and they're very, very committed to the projects that they have. One of the things that I will say that I think anthropology still, because because everybody's doing ethnography now, and everybody talks about culture, so anthropologists, what do we have left? We have our temporality, and we have the fact that we can spend, or we try to spend longer periods of time. You know, the fact that I could sit in these classes, not as a student, not as a teacher, not as an administrator, but for an observer for hundreds of hours is a huge luxury. And so having that temporality in that time, and to be able to go back to UCSF after and maintain that relationship, because a lot of their projects, they're already being pushed to do the next thing. It's like, okay, wrap up your project in Chile, now it's time to go to Mexico, right? I did this field work in 2012 and I'm still working over it. So I think that temporality is one of the things that anthropologists can do. And one of the people at this program, actually medical anthropologists, wrote a very nice piece about slow research entitled Why Slow Research is Good for Global Health. And I think that's one of the interfaces that can be useful, because this, like so many other fields, people are feeling rushed. They're feeling like they have to be on the next grant application, the next project, get the next cohort out. So slow research and its pertinence for global health is fair. I think there's something there. A lot of times I see anthropologists as providing brakes for global health vehicles that are just, especially in Haiti, just barrel through.
Yeah.
So,
Thank you.
maybe an arc that way?
I was quite interested in some of your comments on why MBAs didn't seem to fit in too well to the program. And our example would be at McMaster, the Department of Psychiatry, and this is way back in the 70s, had developed a model originally pioneered at McGill of coordinated, integrated care delivery system that really depended on having networks of services that were indeed integrated. They weren't just a bunch of private practitioners out there doing their own thing in their office. And in fact, McMaster has a long history of pioneering things like health service institutions and delivery systems like that. At about the same time, which was the early 70s, the government was interested in improving the management of health delivery. So they started bringing in MBAs who were imposing a business model on this. The result was, if you want to go back to it, the concept that we as psychiatrists had in that model was the old medical concept based on prevention, public health, and so on, that in effect what we were trying to do was to improve global mental health. And if you want to interpret it from that point of view, put ourselves out of business. We're very confident we would never be able to put ourselves out of business, so we weren't too worried about it. But on the other hand, from the MBA's point of view, what kind of a business model is that? I think we had an inherent clash of cultures when those two things were put together. I'd just be interested in your comments, especially since looking at it from the point of view of leadership.
Yeah.
Because that's where the leadership was redirected.
Yeah. I think it just goes to show how, while some of this may take some new forms, like you're saying, so this was being pioneered in the 70s, right? There are these ongoing tensions, between care, between cost, between resource allocation. And then I think what I find particularly interesting is how, everybody talks about interdisciplinary work. And it's so easy to talk about, and it's so easy to say, oh, this is an interdisciplinary project. But what does this actually mean in terms of what survives an interdisciplinary collaboration? And then we also don't hear about the interdisciplinary collaborations that don't continue, right? Because people aren't interested in publicizing ruptures, failures, the ends of something. And these programs, they don't necessarily, no one talks about what's going to happen after global health education. These programs are being launched. But is there going to be a new term in 50 years? Is there going to be a new paradigm? Are there going to be new academic disciplines or branches of science that mean that this isn't going to be there? It's very possible. But you know, it would be interesting to follow up on that program to see, so what did happen? And as well in the business schools themselves, you know, who I think are in this complicated position of, you know, they're training for business administration. There's a lot of pushback from so many sectors of the university saying we don't want university education to become commodified. So for example, McGill's MBA went from charging the regular provincial tuition, you know, $2,000–3,000 a year up to $30,000 a year. And this created, you know, a big discussion saying, well, you know, this is what the market rates are for business training. And other people saying, well, no, like, who are we going to attract if we put it at that price, right? And so these questions about the meaning of education, the cost of education, and then when you apply it to global health and say, all of this is within the context of trying to improve health conditions around the world, the stakes get so much higher. It's not just about a business surviving or a product being sold. It's really about, you know, making that people aren't dying at age 45, right? So yeah, I think the continuity is really interesting, that it could be still there, and it would be interesting to see, you know, if that project doesn't exist anymore, when and why did it stop, under what terms, and what would people who remember it say about it today?
Thanks, Pierre. It's nice to see how the project is evolving. I have a question I think is similar to some of the other things that have been brought up, and I'm wondering what you think about the possibility that a lot of what you've identified really has to do with the American, maybe North American university culture, and growing economic inequality in the United States. So I'm thinking, for instance, that universities are now being demanded or kind of required to promise social mobility in an era where that is becoming more and more difficult, and that leadership itself is kind of selling you an elite position.
Yes.
And that the stakes are really high because being left out of that kind of position is quite, you know, significant. So, and this idea about the fast, moving everybody through. Universities have to make money because public funding has tanked for, you know, UCSF, for example. And I'm wondering how much of a lot of the phenomenon you're talking about really have to do with, yeah, just American university culture and socioeconomic trends.
Absolutely. I think it's that, you know, that is really at the core of what's happening. So UCSF is a public university charging $40,000 a year of tuition for this program. And when they built it, the idea is that the program would be self-sustaining, so that those tuitions would cover rent, faculty salaries, all of the program expenses. That's why they weren't offering scholarships. They would occasionally get students from the Global South whose governments would pay for them to attend. And so we would have, and this was, you know, very complicated. You would have somebody who's 22 years old, just finished an undergraduate degree in microbiology, sitting next to, you know, the former Ministry of Nursing of Mali. And most of the interactions that I saw were actually quite, you know, cordial and learning from each other and beneficial, and the environment was quite good among these students, and people talked about that. You know, everybody sort of behaved correctly in terms of appreciating the others in their cohort, and there were all these norms in terms of like how to interact with people who might have a different background. But absolutely, and the fact that, you know, these students, so many of them are coming out of undergraduate degrees, and many of them said that they had the project of going to med school. So the other part of this is medical school admissions in the United States, which are extremely competitive, but where UCSF and a master's from UCSF can be very strong for a student's application. And I think that was never far from many of the students' minds of saying, I am doing this, not because they weren't interested in global health, they really were, but the investment that was there, I think, was seen as part of an eventual medical school debt. So the social mobility absolutely promised by university. The other thing, and it's hard for me to address this without it being like very clunky, and I'm trying to figure out a way of talking about it, is about half the students in the cohorts that I talked to had parents who had migrated from the United States from countries that would have been the targets of global health interventions at the time of migration. So from Vietnam, China, India, Sri Lanka, Korea, you know, and some of these countries still are targets of global health interventions. But you know, how to talk about this in a way that's not too you know, I don't want to draw just like immediate lines between these different points. But that dimension of it struck me, so in terms of what kind of investments families are willing to make in terms of education, what are considered respectable and safe career tracks for people who might have experienced a pretty tumultuous migration and you know, coming to North America with some uncertainty. Then the final dimension that I think is interesting is the gendered aspect. This I didn't mention. Out of 42 students in this cohort, 38 of them were women.
The picture you have behind you is almost
Yeah.
entirely women.
Yeah. And I remember presenting this to somebody, and they said, "Oh yeah, global health is going to become the new nursing," you know. And it was that is also something that comes up versus many of the faculty members, lecturers, or rock stars who are older men. And that, you know, I heard the students talk about this dynamic, about the gender imbalance, both in terms of their own cohort and in terms of who they were presented with in career models and the mobility. But yes.
This may sound naive on my part, but and I think there's a real place for critical pedagogy. I really do, and I think you touched on many of them. I really appreciate that. It's almost leaving me breathless, the comprehensiveness over which you can wrap that whole scenario into a lecture. Given all the problems with the difference between public health, global health, all the reasons for wanting to be in a global health program, who's in the program, what demographic do they come from, issues around public versus private funding, and all of those problems with global health programs. My experience has been young people are concerned about social justice, not only locally, but internationally. Where else can they get exposure to different countries and cultures? Where else can they get an opportunity to talk across different class lines, gender lines, what other kinds of lines than in a global health program, which is so rich in opportunities like this, rarely seen in other faculties and departments, I might say. So I think there's not much time left on this planet to get our act together. And there are so many problems that are so complex that do require the perspectives of political science, anthropology, sociology, business, epidemiology. And I don't know how you can deliver all of that pedagogically into one degree program without introducing students to the panoply of the disciplines that they might need, just to provide a soupçon of insight into how they might shine a flashlight into the dark tunnel of progress to some future Shangri-La, if you will, or just even a more just society.
Yeah.
So that is leadership. Shining a bright light into a dark space. Not everybody can be a leader. I really appreciate your comments about the whole medical missionary sort of roots, antecedents to what is now termed leadership. Not everybody can be a leader. There's a place for followers. There's a place for managers, and I don't think management and leadership are the same thing. I think they're quite different.
Yeah.
But project management of large, highly funded projects from the World Health Organization, PAHO, and UNICEF in resource-constrained environments is a good skill set to have. I'm just sort of rambling, actually. I'm trying to create a positive rationale for why there ought to be global health programs. I'm glad they exist. I'm not, I think the comments about the rationale why they exist in certain states in their south of the border or even north of the border is worth critical analysis. But generally speaking, I'm a champion of this kind of education, which is too rare, I think, in academia.
No, and it's such a fascinating field that has attracted such a diversity of people, and I think that's why I find it, I found it so interesting to spend time with them. Is that the projects are so interesting, the cases are interesting, the stakes are high,
Right.
And you also had this feeling in the classroom. Everybody walked out of there every day saying, "We learned about something important today. This mattered," and I think that that is something that is precious, and that I'm curious to see, over time, will these programs continue to multiply? And will they become less about prominence, less dramatic, and will it be sort of a mundane training, you know? Like, if you just think about, if I just think about the reactions when I talk with people about, you know, the Masters of Public Health or a Masters of Global Health, kind of the connotations that come with that. And I think, again, making a very American story about this, what is the public in the United States? What are health inequalities in the United States? What are issues around prominence and wealth and poverty and exclusion? One thing that I felt was talked a lot about in the program was policies, but not about power. And power is difficult to talk about. It's difficult to teach. It's difficult to address. But I mean, we just and the students would talk about it themselves informally. San Francisco is one of the cities in the United States with the most inequalities. I mean, every time I go back there, I'm so struck by the number of people living in the street, the number of people with all sorts of extreme health problems, and then racial segregation. And I mean, it's this kind of beautiful, dysfunctional, you know, dystopian place. I grew up in the San Francisco Bay Area, so it's a place that's close to home, and every time I come back and see it, it's just like, what is happening here, you know? And that was just down the street from, you know, people are in the block learning about arsenic poisoning in Chile. So and there was an awareness of that. But the people who worked in the US kept having to say, you know, Sacramento is global health too. Oakland is global health.
Yep.
Like the people, no one ever said HIV in Botswana is a global health issue. Don't forget, you know, they never had to make that claim. But people working domestically, or people working on chronic issues, are making that claim. It's also because there are resources in global health, and so people are moving towards those resources, whether it be in the form of student tuitions, whether it be in the form of grants, Gates funding. You know, there's a reason why institutions have changed their name and moved towards this. And it's not because they don't believe that they're doing good work, but, you know, thinking about the direction that we're going in, and then thinking about what direction we could have gone in, looking at different models, different ways of doing this, oftentimes coming from the global south, where people are doing it with much less money, and just a different approach and a different version of what is the public, what is society, what is an ideal, what is a good clinical relationship, what is, you know, so much of it comes back to the state, you know, with like what's the state's obligation toward the citizen in terms of clean drinking water and, you know, basic education and primary care. So.
What do you think is the biggest difference in emphasis of global health programs in the global north compared to the global south? I know you mentioned leadership.
Yeah.
I was just wondering if you could touch on that also.
Well, I have to say, and this, another colleague of mine named Claire Wendland, who's done really interesting work in Malawi.
University of Wisconsin.
She's at the University of Wisconsin.
A Heart for the Work?
Yeah, A Heart for the Work. So she studies the training of clinicians in Malawi. Claire Wendland, W-E-N-D-L-A-N-D. She and then my other two colleagues talk about how a lot of these programs in the global south, they have not really been saying that they're doing global health. They do not have the same expectations of mobility or of like, this is going to, you know, make policy for, you know, the region, or a little bit sometimes. So this last training that I did in Rwanda, this came up, and Rwanda is a particular case as well for its prominence and in terms of the quality of its medical training. But there was this one sentence that just kept coming up as saying, you know, this could become the standard of care for the East African region. Like the research that you're doing right here could be applied to Uganda, Burundi, et cetera. And it struck me because it's so rare that you hear that. And, you know, clinicians that I've seen in Haiti, they feel like there's two avenues for them. They may stay in Haiti and practice, or they may emigrate to North America. And 85% of university graduates in Haiti do leave the country. So it's a very high professional migration. And so their aspirations and training is to be able to continue their profession after they migrate, right? To not become a taxi driver, not, you know, have a dry cleaners once they leave Haiti, to be able to continue as a clinician, as a nurse or a doctor. If they're a doctor, to not, you know, become a beneficiaire in Montreal Hospital, right? Like that's what they're hoping for. But that involves Their focus will be on technical proficiency, on medical technologies, and making sure that they're lining up with the Canadian system of care, right? So that's something that even their medical faculties will push them a lot. Be like, okay, well, when you go do your residency in Florida, you won't be able to do, you know, like that's being ingrained in them kind of. I had a colleague who told me once, she's like, you know, from high school, they're telling you if you're a smart student that if you really succeed, you'll leave and you'll be able to help your family from a distance. So that form of what it means to be a global citizen is very, very different. Their eyes are set on migration and they have an awareness. But they will also often emphasize, like, only in Haiti do we see things like this. Only in Haiti would you see, you know, kids dying of worms. And part of my conversation with them is saying, like, actually, these are problems on a really big scale, and, you know, let's see if we can get some material from other places so you don't have this isolation or this feeling of national shame, you know, like, oh, you know, Haiti, lowest life expectancy in the America, blah, blah, blah. It's like, well, actually, you know, Namibia is giving you a run for your money. Let's look at what strategies have been done, you know, and to not frame it exclusively in national terms. And there's some curiosity for that. But I would say, if they have ever heard the term global health, it's because there's a North American organization who started a global health program and it's sending them their students.
So they're doing public health, actually.
Yes, well, community health, some people know that.
Right.
And then kind of the classic pediatrics, OBGYN.
How much of that, like, dichotomy, global south, global north, and the exclusive existence, I would say, of global health in the global north is because of the fact that it's a values proposition? Because global health is, despite all the kind of lip service we give to it being in San Francisco, it being in Canada, like, the global health program at McMaster, for example, doesn't go to Nunavut to practice or to experience global health. We go to India to see what's going on there. And that fetishization of the other, I think, in a large part stems from medical school admissions, because there was from 90s to now, or a little bit before now, there's this big push for, like, if you want to get in, go volunteer somewhere, and that's like your golden ticket in. And as a graduate from a global health program, anecdotal evidence, but the vast majority of my peers, their exclusive reason for going into the program was a ticket to medical school. So has there been some kind of look at the correlation? I think someone already asked about the graduates.
Yeah.
How much of those graduates who are still in school are going to medical school? How much of the graduates who are employed exclusively with a BA and then a global health degree, as opposed to, like, having a MD and a global health degree?
Yeah, and you know, I think it's such an interesting issue to bring up Claire's work again. Claire started working in Malawi in women's health in the early 90s, and I remember asking her, I said, you know, what was it like? What did people at your medical school say when you did that? And she said something like she was considered such an oddball for going to do work in Africa, you know, and I just think, like, you know, in Quebec, everybody sort of has, like, an elderly missionary aunt who spent 40 years in Brazil, you know, and it's kind of like, was eccentric, and, like, you know, you would get postcards from her every once in a while, and she'd come in. It's sort of that figure, you know, of just, like, something that, like, oh, okay, why would you do that, you know? And she said, like, the kind of the thing that people were really interested in at the time was HIV, infectious disease, in kind of the early mid-90s. That's where she saw, like, there was a lot of enthusiasm for that, but not globally. And now, what is it? I saw the national survey from the US, 65% of people entering medical school either intend to or have had international experience. So will it just be a question of time where it's like, well, you know, I volunteered at a clinic in Guatemala for 3 weeks. It's like, that doesn't cut it anymore. You know what I mean? Like, the medical school admissions committees or boards, will they be saying, we want to see sustained engagement, we want to see something that's not purely clinical, we want to see, you know, that kind of opportunity will not be considered enough. And then another thing that made me reconsider all of this was, so Haiti gets a lot of medical missionaries, a huge number of medical mission teams who will go down for a week and do often things like vitamin distributions. There'll be some specialized care, so cleft palate surgeries and glaucoma surgeries, but there's also just a lot of handing out antibiotics and analgesics, right? But to look at the people who are doing this, which, you know, colleagues and I would often like sneer, you know, like, oh, they're all wearing their t-shirts, they're from like a church in North Carolina, like they're talking too loud, and then, you know, to actually sit and talk with these people about how much money it was for them to pay for their plane ticket to go down, what they think that they're doing, the fact that they have not traveled anywhere else in the world, the fact that they don't want to stop doing this because they feel a really profound connection to it. Realize this is also about class judgments, right? And who has access to these kind of forms of international mobility. But then again, you know, they're going for a week-long trip, and their plane ticket from Atlanta to Port-au-Prince, you know, we talk about these equivalencies all the time. What could that money have done if spent differently in the global health economy? And you know, to have someone go down and get vitamins for a week versus, you know, I don't need to tell you how that economy could be used differently. So it's complicated, and you know, as much as I have a hard time with the week-long medical mission, also just it's kind of like the leadership language. I just have to like become porous to hear like, okay, well, what are they saying? Doesn't mean I have to agree with it or push for it by any means, but there was really some unexpecteds in conversations that I had with these mission teams. Yeah. Yes.
So my question to you is, after all of your great qualitative work, talking to the graduates of this program, I'm a physician. I was born in Africa, trained as a physician in Africa, worked in Africa for more than a decade, and was often on the receiving end of well-meaning people like this. Have you ever considered actually speaking to the people on the receiving end in the situations that they were trained to serve, what their experience is and what their needs are? Because in my opinion, that is where the research gap is, having seen it in action many times. So have you had time to actually speak to the receiving end of these graduates?
I did. That was actually the project that led to this one. It was work with Haitian clinicians about international aid. And one of the things that I saw that I think characterizes the beneficiaries' appreciation or critique of these programs is a profound ambivalence. Because many of these programs came with concrete material resources that are necessary for the practice of biomedicine. When they would talk about the aid groups, they would say, they're the ones who send us gloves so that we don't have to reuse surgical gloves. They're paying for electricity in the operating room. This is the organization that keeps our dispensary supplied because my work was in a public hospital. They were not getting anything near the support they needed from the central government. So this is a 250-bed hospital that serves 1 million people that did not have a functioning X-ray machine for 8 years. So how can they not, in a sense, be appreciative, grateful, happy of this coming in? But then, of course, there's a profound resentment that the aid is coming from the same countries that they know historically have kept Haiti in the position that it is, that there are larger economic strategies to impoverish their country going back to the 15th century that the foreigners oftentimes are not very aware of. You know, that, for example, the US military occupied Haiti for 20 years at the turn of the century, and the first thing that they did was take control of the customs office. You know, people in Haiti know this, they remember this, and for them it's like, yes, we have enduring economic ties that you have no idea are there. And so they see people coming in on a blank slate, like, oh, you know, we decided to come help people in Haiti because there was need. And Haitian recipients are not only just aware of everybody who's been coming for years, but they're also aware that they're coming from specific places, and they will have classifications. The ones who want to help us, the ones who don't want to help us, the ones who are here doing experiments on our patients, the ones who just want a tax write-off. There's a very detailed topography, and a very, very strong critique. and then through that some affection, you know, saying like, oh, well, you know, that group really does help us, or like, we would have closed down a long time ago if they weren't, you know, there, or like, my medical textbooks that I use for my teaching, you know, in the Haitian University come from University of Sherbrooke or whatever. So that mix of emotions is something that I think is very, very strong, and that people coming in from the outside sometimes will get a hint of, but are not necessarily listening for. Yeah. Yes?
I just wanted to bring it back to a comment that was raised earlier about the whole medical school admissions. Being in a similar program, so currently being in the Master's Global Health, similar dialogue, everyone kind of wanting to pursue med. It's either a med rejected master's program that you go to if you've been rejected from med school, now you're hoping to redefine your profile so that you'd be accepted, or you are hoping to fill in that void of having that criteria for being the perfect applicant for med schools. And then back to the other comment saying not everyone can be a leader, but everyone wants to be a leader because of how it's talked about and because of the current dialogue around it. So even if not everyone can, we will do such programs that will help us become them. And then can't you argue that there's a huge, like I know you were saying that you find people that they are interested in global health, but I remember the first day of class people start asking like, why did I choose this program? Why are we here? And people start saying, I'm really excited about blank. And I can't remember the last time I was so excited to do global health. Like I'm much more excited to go play volleyball at the beach, and I just don't know how honest and accurate we're like getting students into such programs, and whether there's an honest like reason for people to actually do these cases, or they're looking at that futuristic, okay, I want to be a doctor and this is going to help me get there. Yeah. And if we're creating a population of people that are here to just build a facade, then the work itself is also going to be superficial, and it's also going to be like, so maybe taking a couple steps back, it's that we're actually engineering a population of people that are trying to meet requirements, which then makes the work also quick and like superficial, versus saying that, yeah, people do have interest in global health, or they do have, I'm very cynical to think that that's the case, that all the people in my, or even any majority or minority in my program is genuinely interested in global health.
Yeah, and you know, I think in some ways, global health today is a way to become a smart, moral person, right? Like that's like the international physician, or you know, if we reduce it to clinical work of physicians, like how do you prove that you're a good, smart person is global health, right? Which could have taken different forms in the past, could have you know, the manifestations, but these are the manifestations now that has a particular amount of traction in the wake of the HIV/AIDS epidemic, in the wake of American military prominence, the end of the Cold War. I mean, all of this is big, you know, picture. Big picture issues. I would say that the folks that I met at UCSF, because there was a lot of competition to get into the program, the directors, I think, were very careful about screening people who had had significant international experience prior to applying. And they had the luxury of doing that because there weren't so many programs when they started, because they had a lot of applicants. You know, they said, if you do not have significant experience internationally, and again, like the 1 week or 2 week mission trip to Guatemala does not cut it. You know, everybody in that program spoke a foreign language. Everybody in that program had I would say, significant contact with the health system outside the United States before they applied. That's not to say, though, that all of the programs are able to have that kind of screening when they're admitting applicants, right? Again, UCSF, early on, particularly visible, desirable place to live, they were able to get that kind of applicant pool. In terms of the cynicism, I think it's there. The problem is, how do we access it, right? And how do we get at people's false motivations? And I think one of the things that I set out with my work, and this was a very personal choice in Haiti, was that I didn't want to do expose work because I knew there was so much lousy aid in Haiti, and it's there, and the journalists are talking about it, and I talk about it when it's appropriate in terms of the groups that are racist, stealing money, doing totally ineffective projects. There are a lot of them. But for a long-term anthropological engagement for me, I wanted people who were already self-reflexive. I wanted people who had a critique going where I didn't feel like I had to sneak up on them, and people who were appreciated in the communities where they worked. And that's meant that some of the groups that I've been studying, I've been working with them now for 12 years. And we have a constant back and forth where we argue, we have disagreements, we talk about different priorities, but that contact is there. And so I think that's why part of my presentation may be skewed, where I'm reaching towards people who I think are doing this seriously. But that's not at all to deny that a lot of people will do it because it's a hot subject, because they think it will get them somewhere, because it's just kind of a strategic box to check, you know, or because international travel is glamorous and interesting and easy, and the social rewards, and people will talk about this, they say the moral rewards that you get from your surroundings when you say that you do global health are enormous. You know, it's hard to think of another field where someone would say like, oh my gosh, it's amazing what you're doing, you know, like, oh, that's so great that you're doing that. So getting that constant affirmation, of course, it's going to have an impact on why people continue to go forward in what they're doing. And that's why it's also a shock when they arrive in some of the places where they're intervening and they're not met with this gratitude. They're met with the like, oh yeah, you guys are coming to see patients or steal our organs. Right? And that catches them out of the blue because they expect gratitude and it's not what they always get.
Hi. So I actually applied and got accepted to this program prior to coming here. So it's interesting hearing your perspective on it, because as a student trying to choose between two Masters in Global Health program,
This could have been you.
it could have been. I was looking at that. I was taking your talk sooner because I had this kind of phase in the summer where I was critically analyzing both programs and just seeing like the effects, like you said, where the people are in the future. Like really the education. Like, am I really going to invest this much money to go far away from my family and to study at this location that's super interesting, but also just wondering about the benefits of it really. And I'm still kind of going through that battle of, is this the right way of teaching global health? It's different. Like you said, it's a very new emerging field. Not really sure kind of the effects of it, but regardless, I mean, kind of going through it's still very interesting. I'm just wondering if you could, like, I know it's a pretty broad ask, but if you have any insight or opinions on what the best way of teaching this in a master's program are from your experiences?
A lot of times when like anthropologists give recommendations, they give things that people already know. And it's like, learn the language. You know, this is a lot of the age groups, they would come to me like, what do you think we should do better? I was like, you already know what you should be doing better. It's about putting them into practice, right? I think part of it comes down to something that you said about training generalists versus training specialists. And correct me if I'm wrong, but you said, you know, generalists are being trained so that they know so much.
Less and less about more.
Less and less about more and more, and specialists know more and more about less and less, right? And I wonder if part of it is going to come down to, we cannot expect individuals to do everything on an individual level, right? And this idea, I don't know if it's me being unrealistic and because like I had a long time to finish my PhD, but this idea that you would go into a classroom every day or every hour and be told like, this is just skimming the surface. This is like, you know, this is going to be really fast. Okay, we're not going to be able to cover everything. And then everybody's sort of at the gate trying to get some classroom time with these students. I wonder to what extent that's going to be a good thing in the long term. And part of it also has to do with the information age, with the rapidity of everything just speeding up and going so fast. And it's tricky because the language of emergency does different things, right? Like you can mobilize people, it can get resources up and running, it can say this is really important, something has to happen. But it can also mean that you cut corners, it can also mean that people get trampled along the way, it also means that things are not seen for what they are. And so I think my advice would be, and I don't know if this is a fair thing or if this is just from like a position of privilege, is to say, can we just slow this down a lot? If it involves teaching less, if it involves having fewer like grand ambitions, if it means, you know what, we're going to train you in this and that, and there's another program that does this and that, and we're going to make sure you know those people and that you can respect them and you can connect with them, but you're not going to all be doing it yourself. You're going to be able to have a cross dialogue. And I guess, maybe a sort of modesty in terms of the limits of what can be taught and learned. And then I think my other thing as well is really the extreme mobility in global health I do find worrisome. I think there are some situations where it's necessary, where people do have to do a lot of comparative work and are moving around quite a bit. But what I've seen a lot in Haiti is people will work in Haiti until it gets difficult, and then they will go work somewhere else until that gets difficult, until their project hits a wall, until they burn their bridges, until they've made their mistakes, and then they go somewhere else. And when you find these groups that say, you know what, we are not going to leave, we're going to stick around, we have, and this is why, for example, the contributions of the Haitian diaspora to the Haitian healthcare system are interesting to look at, because they're not featured prominently, they're not very visible. But those people aren't going to start working in Guatemala. Like, what do they care about Guatemala? They're like, it's the homeland, right? And it's like, we have to give back what Haiti gave to us, our youth, our education, our country. It's out of nationalism. So without, saying like nationalism is the answer, or tribalism is the answer, but, engagement and commitment and respect, I think, for temporality, and saying, all right, we're going to keep doing this. It's going to get hard. The program's going to break down, and then we're going to stay there, and we're going to see what happens after, and we're going to, have some continuity, as opposed to saying, well, like, I've interviewed in 40 countries, which it still gets valued a lot. Yes, maybe from the back moving forward.
Sorry. What I also find interesting from your talk, so just to provide context, I graduated from the global health program here. I'd had experience nationally before and then after, and I think it provided some perspective on it. But what I find interesting with this, the growing interest in global health, let's call it that, is there's a lot of people that have worked. For example, I had a lot of interaction with missionaries, and missionaries get a lot of flack for the negative effect they might have had on cultures, racism that they might have propagated. But it's interesting that you have clinicians, you have researchers, you have people that do these mission trips, and they talk badly about missionaries, but they're doing 1-2 weeks. And I knew missionaries that were for 50, 60 years, and they knew the culture, and they were ingrained in it. That was their home country. And people were writing bad things about them versus unstable practices or organizations that came in, like you mentioned, on grants for 4 years or 8 years, and then were gone once the funding ran out, or they had roadblocks with the country.
Yeah, and I saw exactly examples of this, and I will not hide it. Like, evangelical projects in Haiti, I'm not at all on board with the premise, and know where it comes from historically in terms of demonizing Africans in the African diaspora. But they would stick around. Their kids were born in that country, and there was a level of commitment and depth to their engagement with that place that Haitian colleagues respected. Now, it also became very problematic because they would easily become powerful and political figures there with, in many cases, white Americans or white privilege. So it's not simple, but it's true that I think a lot of times we can be very dismissive of certain kinds of religious dimensions of global health, specifically in, if we're coming from secular institutions or position ourselves as secular individuals. But then what I saw time and time again, and I focused on secular groups, I focused on groups that weren't religious, I made that choice. But then to watch their discomfort when they were thanked in religious terms by Haitian partners, who talked about them doing God's work, and Jesus had sent them, and then, you'd have like this like total atheist from like Boston who was just kind of like, what do we do? You know what I mean? Like, is this the time where I take my stand like as an atheist, or do I just like say thank you, bless you too? So that dynamic I think hasn't been resolved. Yeah, and again, people are observing each other, being like, what's their model? What are they doing? How are they doing it? And looking. So there's formal training, but that old style of apprenticeship is still there. And I think the missionaries, whether or not we agree with what they're doing, they continue. Long-term missionaries continue to be a model for short-term missionaries, because short-term missionaries often will stay with long-term missionaries or be in structures that were set up by long-term missionaries. So the rules, the protocols, the guidelines, the way of interacting
are also having an influence. And that I find fascinating, how all that informal knowledge gets transmitted.
So I think the mark of a successful talk is that everyone is asking questions, and I've seen everybody ask questions, and there's even more questions to go. So I'm going to ask that we move to informal conversation with Dr. Minn, that we eat all of the cookies. You don't have to drink all the coffee, but you eat all the cookies. And thank him for trekking it out here from Montreal to talk to us today. Thank you so much.
Thank you.
So I'm not going to feed him dinner until you ask all your questions. So please don't be shy. Come on up. Close all these things. Yeah. I'll figure out what we do with the system.
Yes, thank you.
I think we probably let's shut down. Right? That works?
How are you waiting for your trip?
How do we turn the projector off?
More than insulting. No. They came in from the
Yeah.
I think there's a open role for reading a balance sheet. Allocating resources to high priority projects.
Well, yeah.
Yeah, I'd be So there's a sheet, Monica True, how it's done, demonstration projects, let's just see.
The other person, yeah.
Who's working in South Africa, in nursing school, who's learning how to read a balance sheet or understand input, throughput, and everything. So there's a role for project management, leadership, engineering 101, what have you. So those disciplines inform the clinical judgments. Just as anthropology is a way to just as
You know what I can do? I can just email this guy.
that you can analyze why some people are healthy and others don't, why are some nation states wealthy and others not, right? Yeah. I think that's the we're not telling you.
Oh, it looks like
Do you want to come to the meetings with a couple of old students?
Yeah. That confers
You're welcome as well.
by itself.
Yeah.
Innate knowledge about how
We're heading over right now. We're just going to talk to your students. So.
it's funny because I remember you learned, and it's like I would not, but I worked at a lot of outside.
Like it's very based on leadership and like project work and problem finance. Yeah, problem with it that I also had from more of an observational, less experiential. Sorry,
It's a good observation. Yeah, okay. Because they talked about, I took
Yes.
And interestingly enough, I worked after completing the master's program here. I worked in Senegal for 2 years. Yes.
He's the latest NASA guy. Problem is, the company wasn't allowed to show the success rate. There's no Lighthizer what you mentioned. His definition was to know the leverage of the other person. So when he was Canada versus US, Lighthizer knew that we were sensitive to each other.
We get a lot of
That's normal. That's the more sensitive to steel and the auto side. So he those you described you know, there's a little arguments and not all of anyway, that's quite a while. I saw everyone else out of the oh my God.
I was waiting for someone.
People think I had every guy.
Taking on a lot of like, I know event coordination. We'll see if you get any money, so, but, you know, good for you. Good for you. Oh, you love it. Oh, yeah.
I say, I wondered if you have.
No, I didn't. There's a exposure to something I never got to know. It was a learning experience.
Yeah, well, I'm glad to hear that.
Well, she's an educator, right?
Yeah, that's right.
She's interested in different things. We were having a conversation about that at lunchtime. They're just
why are there structural
barriers? Different styles of stuff. Some people who are like, I love learning new things.
So it's also
learn something. It's so exciting and it's like we're learning stuff.
A lot of people who are invested in
it's not my field. It's not exactly what I
hero nurse in
Europe or whatever. Like everybody goes to her and she's all the time.
It has to be spread
I
over
had actually seen this work when I was at the university.
And he did that
often because that's where I was before I came here. And
that's the kind of subject that's
who had been a part of
some nation states poor. Why is it that one nation state has the worst health
climate? And so, what do you think? And you probably know this.
Something structural wrong.
So,
Probably.
Well,
clear history.
So there you go. So I mean, that's the subject that should be taught.
Great for the next project.
I don't think so. I think like because that would be a globalization. That would just be the history of like how things have happened. I think forward-looking, and yes, that involves like a historical perspective. But I don't know if your comment is well said. The majority of what we are supposedly trying to do programs is program management. Like yeah, but I don't think anyone should graduates from that program.
All kinds of people who sort of keep tabs on them. And they become a volunteers who sort of keep an eye out. And so there's a friend in there who was actually
but no. So
I've
I
never
just
seen this talk that's, you want to amend, so when I
going to another
See that, so I was just about to ask that.
and it's, I think what's really great, maybe with a better smaller room, but it's, thank you so much.
You're welcome.
There's a big packed crowd, and it's full, but then there's not questions.
I'm just kidding.
Yeah,
and I want to.
The mark of a success.
Because India's not even
Yeah, a lot of,
and then
like very critical work and colonialism and all that, and like
I think now there's
just like very advanced dedication and going out research for doing that, only doesn't help the system research. It's very, I think it's very genuine research to the talking about education strategies and things very top down. A lot of their research is very quantitative in their approach that they try to use it's about like research methods, it's about finding ways to do quantitative research or base policy on that, which I find like with my background, I find that
colleagues on the CI
kind of very problematic is the whatever, but it's very, there's obviously like a lot of benefits. So like this is very, and like, you know, and they're now working like heavily based on like social systems research, or like economic policy, or
and also ask people
or like promoting gender equality, the justice system, or things obviously applying this kind of same approach of like, let's get some of the randomized control trials, let's do a very systematic, rigorous literature review, let's maybe get your relations and let's base policy on that, because our staff is so bright, and so I got into this very from a very critical perspective, and I don't know, and so that's why I'm like trying to figure out kind of where the opportunities are to kind of be involved, but in a critical way as opposed to being the person doing it.
But it's great if you're still
yeah, I don't think that was kind of and that's the problem. Like we're going there, we're using them as a learner, we're instrumentalizing people, and then coming back and justifying it as like the greater, like our learning is for the greater good, and that's the problem. And so I think the big thing that I with Dr. Gombe was if we're going,
the publisher is also
like implement the things that we don't have to there should be some reciprocity. Like, as it stands, the community and I would argue to an extent the students at money calls are not gaining as much from that interaction as we are. And that fundamental imbalance of power is the issue. When you go to Norway or Oslo, that power imbalance is there.
And I do think like in general, good scientists understand the limitations of the work that they do, right? Yeah, and then like
not taking that.
Wow, it's just like there is
Close your eyes and open
are like opportunities to bring that perspective to like public health or global health.
So it's interesting. It's really interesting.
It's all electronic.
And the two of them are so much really experience with applied
What is your
dealing with people, trying to help vulnerable populations, right? Has limited means. There's this plan to do this, but what about tribal players? That I do. Doesn't work. That doesn't work. It's a great idea, but you need to see it.
In the book,
That's the other thing.
Metrics.
When I first went to Morocco, I was 25 years old, unmarried.
Yeah, thank you.
I'm talking with this Moroccan.
They have well, they have like a scholarship, which is exactly a scholarship for global health. Right?
I didn't know.
Yeah,
They were totally right.
You know, it's like just do it. I don't know what I'm talking about.
Yeah.
But
that's all good.
yeah, but it would be great to do it and be able to